Hello, my name is Valerie Leonard, and today I am here to present the magnesium treatment on methylation changes of transmembrane serine protease 2. Before I begin, I want to give a little bit of an itinerary of what I'm going to do and what order I'm going to talk. I'm going to go over some background information about what inspired the study and a little information on magnesium. Next, I'm going to talk about the objective of this study. Then I'll go into the study design and how things were set up and why things were chosen as they were. Then I'll briefly talk about the participant population. Then I will dive into the results. And at the end, I will give my thoughts and opinions about the study and what I found interesting. Before I start, I kind of want to talk about COVID-19. I know the past 2 years, we've all lived in a COVID-19 world and have been dealing with this every single day for the past 2 years. But at the time of this recording, 481 million people have been diagnosed with COVID-19 worldwide. And unfortunately, 6 million people have died from this disease. This information is from Johns Hopkins University website. They have an interactive COVID-19 map. You can look at specific countries, you can look at specific states, or you can look at the worldwide population like I did. I did add the link down below if you wanted to check it out yourself. Okay, diving in, we're going to talk about the background of this study. So the study that I am doing today is actually an ancillary study from the Personalized Prevention of Colorectal Cancer trial. So this was a double-blind randomized control trial conducted by Vanderbilt University. In this trial, 236 individuals from the ages of 40 to 85 were selected. And these people had been diagnosed with adenomas or hyperplastic polyps from the years of 1998 to 2014. The study looked at participants' calcium intake from above 700 milligrams, but still below 2,000 milligrams a day. When they assessed how much calcium they're taking in, they then assessed whose calcium magnesium ratio was above 2.6. And they based this off of two baseline 24-hour recalls. At the end of this study, it is suggested that calcium magnesium ratio about 2.3 has significant effects on vitamin D absorption. So how this would work, they are specifically looking at vitamin D resistance, like treatment resistance. And they found that people with low magnesium also had low vitamin D. So when treating vitamin D and if they had resistance, they would then pair magnesium with it. And it seemed to help the absorption process in the body. They specifically looked at magnesium-dependent vitamin D resistant rickets. And when adding magnesium with vitamin D to the specific patient population, it seemed to really help with the rickets signs and symptoms. Some further background when looking into magnesium specifically, magnesium may optimize the body's vitamin D status, which can affect acute respiratory distress syndrome through the activation of vitamin D signaling and reducing cytokine storms. This means that the magnesium will help the vitamin D maintain the body's pulmonary system integrity. Magnesium deficiency can increase a risk of cardiovascular disease, hypertension, coronary heart disease, heart failure, and thrombosis. It has been found that magnesium really does play an essential role in low magnesium can promote pro-inflammatory or pro-thrombotic systems in the body that can lead to cardiovascular disease and potentially more severe COVID-19. Lastly, the magnesium deficiency caused by a gene mutation has been shown to reduce active T cells, and this can increase the viral loads in the body, which again can contribute to a more severe COVID-19. A study was found that people with COVID-19 carry apolipoprotein E, or ApoE. They are more at risk for COVID-19, but with some magnesium treatment, there may be a demethylation of the ApoE gene, which can increase ApoE levels. Okay, jumping into the objective of this study. The objective of this study is to be able to use magnesium treatment to methylation changes of the transmembrane serine protease 2, which I will refer to as TMPRSS2 from the rest of this study. Again, this is inspired by the parent study, personalized prevention of colorectal cancer trial, and they are seeing if this can be repeated and to see if the outcomes can be beneficial to COVID-19 patients in reducing COVID severity and mortality. So the goal of this study was to maintain a calcium magnesium ratio of around 2.13. Diving in a little deeper into the study, they looked at the methylation of 5-methylcytosine, or 5-MC, and how that is associated with the transcription repression of TMPRSS2, whereas 5-hydromethylcytosine, or 5-HMC, is critical in maintaining the gene expression of TMPRSS2. So how magnesium plays a role in this is that magnesium affects the metabolism of the key factor for the translocation enzyme, which can catalyze the oxidative process from 5-MC to 5-HMC. This study type is actually a randomized controlled trial. It was set up as a double blind to minimize variation between participants and lab staff. That way, no one knew who was taking the placebo or who was taking the treatment, to make things as even as possible when collecting all the data. 250 people were recruited. However, 240 people finished the study. One person was considered not truly finish the study because they did donate blood at the end of the trial, which did mess with their magnesium levels, so it could not be counted. So truly only 239 people completed. When looking at the data, however, only 224 points were used, and this is because there are 6 quality control steps. I will go on to the next page and talk about that more, but for now, just know that 224 data points were used. Again, to keep things as even and as fair as possible, the DNA extraction was used with the QIA-AMP DNA kit. The researchers cross-referenced this DNA kit with 3 other studies to ensure it was complete, it was fair, and it was as consistent as humanly possible to prevent any biases. These are the 6 quality control steps that were used in this study. The first one, they excluded low quality probes where detection p-value was above 0.05. CPGs is a transcription start site. So they excluded the CPGs with a detection rate greater than 95% and samples with a percentage of low quality methylation measures greater than 5% or an extremely low signal of BS probes. They excluded extreme outliers defined by Tuckey's method based on average total signal value across CPGs. Tuckey's method is a standardized range, is very similar to the distribution of a t-test. Just for an idea of what Tuckey's method is, it's just to identify what the outliers are and how to calculate them. So then they were able to exclude those extreme outliers. Next, samples were pre-processed using the R package EN mix to improve accuracy and reproducibility. This is really important for a lot of studies to make sure that it can be done again, especially something like a randomized control trial. You want to have information in your standards to be able to be reproduced by other people for future outcomes and more beneficial findings that we could have with other methods or with more research that will come out. Next, the dye bias was corrected using regression on a logarithm of internal control probes. And lastly, extreme outliers of beta value across samples, again, defined by Tuckey's method, were set as missing. Looking at the two groups for the placebo and the treatment, there was no statistical difference between the two, between age, sex, BMI, hypertension. It was all very similar. There is one thing that really stood out to me when looking at the entire population. However, I will get into this, some of my thoughts and opinions, and I will dive a little deeper and kind of dissect it a little more. But overall, the two groups are extremely similar and they seem very well balanced. So it does seem like a true randomized control trial. Okay, looking at the results, based on the two 24-hour dietary recalls, the calcium magnesium ratio for the treatment were at a baseline level between 2.27 to 3.87. Over the next 12 weeks, 4 more 24-hour recalls were conducted, and that calcium magnesium ratio remained at their goal 2.13 to 3.51. In this study, it was found that personalized magnesium treatment increased the 5-MC methylation at the TSS1500, that is a promoter site, by the way, by 7.2% compared to the placebo group. And these are for ages younger than 65. This difference remains significant after adjusting for age, sex, and baseline evaluation. Compared to the placebo group, the magnesium treatment appeared to increase the 5-MC at the same promoter site when adjusted for age and sex. However, this is where things start to go wrong. This significance disappeared when adjusting for a false discovery rate. So in this study specifically, they use the Hachenberg's approach. And what this is they take the sample size of 240 and they determine how many of their tests will become false positives or false negatives. And they adjust for that. And they had the rate of 0.10. When they adjusted for this finding completely disappeared. So it didn't really seem like much was found at all for this specific treatment site. Likewise, the same magnesium treatment appeared to affect the 5-HMC levels compared to the placebo after adjusting for age and sex. But that effect was not significant after further adjustments of the baseline levels. Just as a reminder, the 5-HMC does activate that TMPRSS2. So once they were able to adjust for baselines, they saw that all the progress that they thought was there had disappeared and that really nothing was able to be found. So kind of diving into my personal thoughts and opinions of this study, I want to start out with population size. So this population was 250 participants were recruited. Again, the 224 were used because of the quality control. But looking at where the study was done, it was done through Vanderbilt University in Nashville, Tennessee. And looking at Nashville's population and its diversity, this study does not reflect Nashville at all. So Nashville has a population of about 600,000 people. And for being a smaller city, I understand that the sample size is going to be smaller. However, Nashville is much more diverse than this study is letting on. 98.8% of the participants were white, and that is not reflective of the Nashville, Tennessee population. And for how big Vanderbilt University Medical Center is and how big of an outreach they have, I found that they could have had a better diversity population. Specifically, kind of referring back to the study, they do make a point of talking about race. And to quote the study directly, it says that the TMPRSS2 plays an essential role in facilitating SARS-CoV-2 entry. Higher expression of the TMPRSS2 may relate to higher viral loads in the host, and that could cause worse clinical outcomes. This has been supported by a recent finding that Black people who are disproportionately affected by severe COVID has significantly higher average gene expression of the TMPRSS2 compared to other races and ethnicities. So when reading this in the discussion, I just found that adding that information, but not having a study that could even possibly reflect the population of Nashville, or even suggest if this study could do very well in a more diverse population, I thought was very odd for them to do. So just going forward, I would hope that they would add a more diverse population. And since they already adjust for age and sex in the baseline levels, maybe then they could adjust for race and see if certain racial populations do better or worse with this magnesium treatment, because so far this study looks like it's really catering to a fairly white population, and that's not really reflective of most people. Next, I kind of want to talk about who COVID-19 affects the most. So higher mortality rates and higher severity is seen in people ages 65 and up. And looking at the clinical findings of this study, it seems that the magnesium treatment is not significantly effective in reducing the TMPRSS2 gene in people in the ages above 65. So kind of thinking back to the past 2 years, we have known that our older population is the more vulnerable population. And when you're older, you have more risk factors for other illnesses. So having the study done and seeing that is not very helpful for people ages 65 and up doesn't seem very effective in the most vulnerable population. This study was done in May of 2021. So this was in the midst of the vaccine rollout and before any major pharmaceuticals were on the market. So as more pharmaceuticals are coming out, maybe adding magnesium could help reduce the viral load, could reduce the TMPRSS2 expression with the aid of other medical interventions. Lastly, I want to talk about the parent study that this is inspired off of. At the very end of the discussion, it was mentioned that the expression of TMPRSS2 was not measured in the parent study. This means that the association between the DNA methylation changes in the level of TMPRSS2 expression and the phenotype patterns cannot be confirmed. I just found this rather odd that this whole study was based off of that parent study and they cannot confirm whether or not the DNA methylation changes can truly affect the phenotypic patterns that are seen in the study. It does appear to have a reduction of the TMPRSS2 expression, but without further studies, we can't confirm nor deny. And I personally found it a little strange to make such a comparison off of that parent study when they personally did not test that themselves. This is my reference. I really actually enjoyed this study overall. I thought it was very informative, and there's so much to be learned about COVID-19, and I'm so excited to keep learning about it. I think that more research has to be done on magnesium treatment specifically. I think there could be a lot of great things to come out of it. So I don't think we need to stop here. I think we need to keep learning and to see what can come of it, and see if maybe adding other pharmaceuticals or trying something else may be more beneficial for older populations or a more diverse population. And I'm really excited to see going forward how this plays out. Well, thank you for your time. Thank you for listening. And I hope everyone has a great day. Thank you.